Hello, my name is Nupur Shah and today's topic is ACL tear part 2. In the first part of the video, we saw about the clinical aspect regarding ACL tear. We saw what is ACL, how many cruciate ligaments are there in the knee, what are the functions of ACL, the primary function and the secondary function, what is the mechanism of injury and which population suffers more because of this tear. So in this video, we will see some more aspect about rehabilitation. We will see what are Coopers and what are non-Coopers, and we will see that if females are more getting this injury more as compared to males, then why are the females suffering more? So that differences we will see the intrinsic and the extrinsic factors. So here we begin. Moving on to the introduction. So this slide explains about the extrinsic factors which are there in the females because of which there is more chances of getting ACL injury in them. So more than 70% of the injuries of ACL is happening because of the non-contact mechanism during the activities of sports such as cutting or landing, and females perform these activities of landing or cutting with dynamic valgus position of the knee, and this creates high valgus forces at the knee while landing, and so it becomes more susceptible to ACL tear. The second factor is that landing from the jump with minimally flexed position, there is greater activation of the quadriceps as compared to the hamstrings, and so here there is muscle imbalance which is happening between the quadriceps and the hamstrings. And if quadriceps is more activated as compared to hamstrings, then the anterior translation will be more, so the stress on the ACL will be more as the tibia will be getting anterior translation little bit higher than the normal. And it is said as per research that females are having more hip abductors weakness, especially gluteus medius weakness, and when they do activities of sports or when the athletes play his or her game with gluteus medius weakness, then it is prone to get more fatigue, hence it is more prone for getting this ACL injury, because hip has direct connection with the knee. If the hip abductors are weak, we have seen in each and every knee pathology that in knee pathology we equally treat hip abductors as main treatment, because if hip abductors are weak and if we keep on treating the knee aspect, then it will not work, the recurrence or the pain will not subside. So what are the intrinsic factors? Intrinsic factors are intercondylar notch size is smaller in the femur of the female as compared to males. Second is inherited ligament weakness. Third is physiologic laxity, and fourth is abnormal hormonal level or altered hormonal level, especially of the estrogen during the ovulation phase. So all these intrinsic factors we cannot change it, it is not in our hands, but we can focus on extrinsic factors as much as possible, and because of that, because of extrinsic factors, we should do sports specific activities, we should give proper training so that the dynamic valgus is less during the landing activities, and there is no muscle imbalance between the quadriceps and hamstrings, hence we can reduce the occurrence of ACL tear in females by focusing on the extrinsic factors. So what are Coopers and non-Coopers? The patients who are better at actively stabilizing the ACL deficient knee through complex neuromuscular patterns, they are called Coopers, and they return to full activity despite of being ACL deficient with no instability for at least 1 year. So the Coopers are the ones who has got ACL tear, but by compensating mechanisms such as muscle activation or physiologic responses or musculoskeletal strategies, they cope up and they get back to the game, get back to their activity with no instability, at least till 1 year. So they somehow adopt it. The ACL deficiency is not so much prominent and there is no instability in Coopers, but in non-Coopers it is not the same. So what are non-Coopers? These are the patients who are not able to return to activity and tend to demonstrate a joint stiffening strategy. Pertubation training is helpful in such type of patients. So the non-Coopers are the ones who are not able to return to the activity and they demonstrate joint stiffening, and it is equally important, it is more important to focus on the non-Coopers and give them proper training so that they can return to their activity or the game as soon as possible. So moving on to the perturbation training, which is being discussed in this slide, and this is mainly to improve the neuromuscular awareness, to improve the neuromuscular response and increase the dynamic stability of the knee joint after ACL tear or after ACL rehabilitation. So after 12 weeks, the perturbation training should be given after 12 weeks of ACL reconstruction. This is as per research. So what are the criteria which the patient has to follow before we start the perturbation training? So these are the three mentioned criteria which we should keep in mind before starting the perturbation training. First is normal gait, range of motion, SLR and minimal knee effusion. Second is single limb stance should be possible without support for more than 60 seconds. Next is single limb squat should be more than 45 degrees with no functional genu varus or valgum, and there has to be good pelvic control while doing single limb squatting. The patient should not lose the balance, the patient should not fall the pelvis on one side. Hence, and the patient should not go for genu varum or valgus while standing on single limb or while doing the squatting on single limb, and it should be more than 45 degrees. So these are the criteria. If these criteria, if at all it is fulfilled, then only we can go for perturbation training. So what are the three types of perturbation training? The first is roller board, the second is tilt board, and the final one is roller board and stationary platform perturbation. So these are the three which are shown, which we just discussed. So after doing the perturbation training for few sessions, few initial sessions, we have to progress the perturbation training. And how do we progress? So these are the methods of progression which is mentioned. First one is predictable and rhythmic to random. So initially we will tell the patient that a perturbation force will be given to them, and they have to balance as much as possible. They should not fall. Okay, so, and later on it has to be random. So we have to give a patient the random perturbation force without informing them. Next is initially we have to give weak force, obviously, because the patients are not used to it, and then we can increase the forces with subsequent sessions. Next is small translations to large translations, doubling stance to single limb stance. Visual feedback initially should be used, and later on eyes has to be closed. And last is sport specific distractions such as ball tossing or dribbling during perturbation. What are the criteria for successful outcome with non-operative treatment for ACL injury? So how do we choose that the patient will be fine with ACL tear by non-operative treatment, conservative treatment? And here are some criteria mentioned. First is no evidence of effusion, full passive range of motion, full knee extension with SLR on the uninvolved limb, quadriceps femoris maximal voluntary contraction force on the uninvolved limb equivalent to 75% of that on the uninvolved limb, tolerance for the single leg hopping on the involved limb without pain, no concomitant ligamentous or meniscal injury. They say that if the patient is suffering from ACL tear along with meniscal injury, then there are chances for developing early arthritis or arthritis in later in the life. So these are the criteria for choosing the patient for non-operative treatment. These are the basic guidelines for ACL rehabilitation, means the basic protocol you can say. Achieving a full range of motion and complete reduction of the inflammation, early weight bearing and range of motion, with early emphasis on obtaining full passive knee extension. There should not be any extension lag. Early initiation of quadriceps and hamstrings activity. There should not be any quadriceps weakness by the end of the rehabilitation, at least after 5 months of the rehabilitation, because quadriceps tend to be inhibited after ACL tear. So we have to focus on it, and we have to get back the muscle activation to normal. If efforts to control the swelling and pain to limit the muscular inhibition and atrophy. Neuromuscular and proprioception training should be started once the criteria has been followed by the patient. For example, perturbation training, which we just discussed, and sport specific training has to be started as per his activity of the athlete. And if the patient is of normal population, then sport specific training should not be done, but high level of functional activities needs to be done in the end stage of rehabilitation, and regular follow-ups should be done, whether he is the athletic patient or the normal person. So that's all about this video. I hope this is helpful. Thank you.